Hello everyone, I'm Janaea Scott, and today I will be presenting on the placental growth factor testing for early detection of preeclampsia. Preeclampsia is a serious complication of pregnancy that affects millions of women worldwide and can have severe consequences for both the mother and the fetus if it is not detected and managed early. Recent advances in diagnostic medicine have identified important biomarkers that help clinicians identify patients who are at risk earlier in pregnancy. One of the most promising biomarkers is the placental growth factor, or PlGF, in, or PlGF. In this presentation, I will discuss what preeclampsia is, the biological mechanisms that cause it, how PlGF testing works, and why it may improve diagnosis and patient outcomes. Preeclampsia is a pregnancy-related hypertension disorder that typically develops after 20 weeks of gestation. It is characterized primarily by elevated blood pressure, but it can also involve damage to multiple organ systems, including the kidneys, liver, and brain. One of the classic clinical findings associated with preeclampsia is proteinuria, which is a presence of excess protein in the urine. If the condition progresses, it can lead to a more severe complication called eclampsia, which involves seizures and can become life-threatening for both the mother and the fetus. Because of these risks, early detection and careful monitoring are critical in preventing severe complications. Modern research suggests that preeclampsia is not simply a blood pressure disorder, but rather a disease rooted in abnormal placental development and vascular dysfunction. Preeclampsia can be classified in several ways, most commonly based on the timing of onset and severity of symptoms. First, the condition may be classified as early onset or late onset. Early onset preeclampsia occurs before 34 weeks of pregnancy and is generally associated with more severe placental dysfunction and poorer outcomes for both the mother and the fetus. Late onset preeclampsia develops after 34 weeks and is often less severe, but still requires monitoring. The condition can also be categorized by severity. Patients may develop preeclampsia without severe features, which may include mild hypertension and minimal organ involvement. More serious cases involve preeclampsia with severe features, which may include complications such as seizures, severe hypertension, or a condition known as the HELP syndrome, which claims the lives of many women. That is characterized by hemolysis, elevated liver enzymes, and low platelet counts. The pathophysiology of preeclampsia begins in the placenta during early pregnancy. Normally specialized cells called trophoblasts invade the uterine wall and remodel maternal spiral arteries to allow increased blood flow to the developing fetus. In pregnancies that develop preeclampsia, this remodeling process is incomplete. As a result, the placenta receives reduced blood supply and becomes relatively ischemic. The stressed placenta then releases an inflammatory and angiogenic factors into the maternal circulation. These substances damage the lining of the blood vessels, known as the endothelium, throughout the body. This widespread endothelial dysfunction leads to the classic maternal symptoms of preeclampsia, including hypertension, vascular inflammation, and injury to the organs, such as kidneys, liver, and brain. One of the most important molecules involved in the disease process is placental growth factor, or PlGF. This protein normally promotes the growth and development of blood vessels within the placenta. Healthy levels of PlGF help maintain proper circulation between the mother and fetus. However, in pregnancies that will develop preeclampsia, PlGF levels decrease significantly. At the same time, another protein known as soluble FMS, like tyrosine kinase 1, increases. This protein acts as an anti-angiogenic factor, meaning it blocks the activity of molecules like PlGF that promote blood vessel growth. The imbalance between these two factors disrupts vascular function and contributes to the endothelial dysfunction, as previously mentioned, that characterizes preeclampsia. Because of the role these proteins play in the disease process, clinicians can measure them in the blood to help diagnose or rule out preeclampsia. Two main testing approaches are used. The first approach involves directly measuring the concentration of PlGF in the blood. Research has shown that very low levels of this protein are strongly associated with the development of preeclampsia. The second method evaluates the ratio between SFLT1 and PlGF. This ratio reflects the balance between anti-angiogenic and pro-angiogenic factors. A ratio of 38 or lower has been shown to effectively rule out preeclampsia within the following week in women who are suspected of having the condition. One of the biggest advantages of PlGF testing is its strong diagnostic accuracy. Studies have reported sensitivity rates around 96% and negative predictive values approaching 98% when evaluating women with suspected disease. This means that if the test results indicates low risk, clinicians can be highly confident that the patient will not develop preeclampsia in the near future. This allows healthcare providers to make decisions more quickly and avoid unnecessary hospital admissions or monitoring for patients who are unlikely to develop complications. At the same time, high-risk patients can be identified much earlier and monitored way more closely, which can reduce severe maternal complications. PLGF testing may also improve the efficiency of healthcare systems by accurately identifying low-risk patients. Hospitals can reduce unnecessary diagnostic testing and prolonged observation. Patients who are determined to be low risk may be safely discharged earlier, which reduces the burden on healthcare resources. Meanwhile, patients who are identified as high risk can receive the additional monitoring and intervention that is needed. This targeted approach improves resource allocation while still prioritizing the patient's safety. Despite its benefits, PLGF testing does have limitations. It is intended to complement traditional clinical assessment, not replace it. Physicians must still evaluate symptoms, blood pressure, and laboratory findings to make a full diagnosis. Additionally, PLGF levels alone cannot determine the timing of delivery, which remains the definitive treatment for severe preeclampsia. Another limitation is the access to the test varies depending on healthcare systems and geographical regions. Ongoing research is also needed to determine whether routine screening with PLGF improves outcomes in women who do not yet have these symptoms. This is vastly important for the women in the US as our maternal death rate, unfortunately, has steadily been on the incline. Future research is exploring several ways to expand the use of PLGF testing. One possibility is the use of serial PLGF measurements, which could help monitor disease's progression over time. Another area of investigation is incorporating PLGF into first trimester screening protocols between 11 and 14 weeks of pregnancy. Researchers are also studying whether combining PLGF testing with uterine artery Doppler ultrasound could further improve early prediction of preeclampsia. Finally, because women who develop preeclampsia have an increased risk of cardiovascular disease later in life, biomarkers such as PLGF may eventually help physicians identify women who would benefit from long-term cardiovascular monitoring. In conclusion, preeclampsia is a complex pregnancy disorder that arises from abnormal placental development and systematic vascular dysfunction. Biomarkers such as PLGF have significantly improved our understanding of the disease and offer promising tools for early detection and better risk stratification. Although PLGF testing is not a replacement for clinical assessment, it represents an important advancement in maternal fetal medicine and may help improve outcomes for both mothers and babies as diagnostic strategies to continue to evolve. Thank you. That concludes my presentation.